Welcome to the MRCPology channel for a quick review and understanding of the topic. Imagine a patient suddenly develops right-sided weakness, vomiting, a severe headache, and then becomes drowsy. In the exam, the key question is this an ischemic stroke, an intracerebral hemorrhage, or a subarachnoid hemorrhage? That distinction matters because thrombolysis may help ischemic stroke, but it can be disastrous if there is bleeding. Hemorrhagic stroke means an acute neurological deficit caused by bleeding either into the brain parenchyma, into the ventricles, or into the subarachnoid space. The damage comes in three linked ways. First, blood directly injures brain tissue. Second, the expanding hematoma raises intracranial pressure. Third, raised pressure reduces cerebral perfusion pressure, so the surrounding brain can become secondarily ischemic. To understand hemorrhagic stroke, think in two main boxes: intracerebral hemorrhage and subarachnoid hemorrhage. Intracerebral hemorrhage is bleeding into the brain tissue itself. The classic MRCP cause is chronic hypertension. Long-standing hypertension damages small penetrating arteries, causing lipohyalinosis and Charcot-Bouchard microaneurysms. These vessels then rupture, classically causing deep bleeds in the basal ganglia, thalamus, pons, or cerebellum. Cerebral amyloid angiopathy is another important cause, especially in older adults. Amyloid deposition makes cortical and leptomeningeal vessels fragile. That is why amyloid angiopathy tends to cause lobar bleeds, often closer to the cortex, rather than the deep bleeds seen with hypertension. Other causes are important because they change the next investigation or treatment. Anticoagulation increases bleeding risk and needs urgent reversal. Arteriovenous malformation or aneurysm should be suspected in younger patients or unusual bleeding patterns. Tumour, coagulopathy, and sympathomimetic drugs can also present with intracerebral hemorrhage. Now link the mechanism to the clinical picture. Bleeding forms a hematoma. The hematoma may expand, and surrounding oedema develops. This creates mass effect, raises intracranial pressure, and reduces cerebral perfusion pressure. Blood breakdown products then trigger inflammation and excitotoxicity, causing further neuronal injury around the bleed. So the neurological deficit is not only from the initial bleed, but also from expansion, swelling, pressure, and secondary injury. Clinically, hemorrhagic stroke usually presents suddenly, like other strokes, but there are clues that suggest bleeding rather than pure ischemia. Headache, vomiting, seizures, reduced Glasgow Coma Scale, and rapid deterioration are all red flags. Vomiting and reduced consciousness suggest raised intracranial pressure. Seizures occur because blood irritates the cortex. Rapid worsening suggests hematoma expansion or swelling. The site of bleeding gives useful localization clues. A deep basal ganglia bleed commonly causes contralateral weakness or sensory loss because the internal capsule and nearby motor pathways are affected. A pontine bleed is a major emergency. Think coma, pinpoint pupils, and quadriparesis, because the brainstem contains consciousness pathways, pupillary pathways, and descending motor tracts. A cerebellar bleed may present with ataxia, vertigo, vomiting, and headache, but the dangerous complication is hydrocephalus or brainstem compression. MRCP trap, a cerebellar hemorrhage can deteriorate quickly, so early neurosurgical discussion is vital. Subarachnoid hemorrhage is different. Here, blood enters the subarachnoid space, classically from a ruptured berry aneurysm. The classic presentation is a thunderclap headache, sudden, severe, maximal at onset. Patients may also have meningism, photophobia, vomiting, syncope, or reduced consciousness. Meningism occurs because blood irritates the meninges. Do not confuse subarachnoid hemorrhage with migraine or meningitis when the headache is abrupt and explosive. Diagnosis starts with immediate non-contrast CT head. This is the key first test because it rapidly distinguishes hemorrhage from ischemia and shows the location of blood. In suspected subarachnoid hemorrhage, CT is most sensitive early, especially within 6 hours of onset. The key clue is timing. A very early CT is much more useful than a delayed CT. Immediate imaging is especially important if the patient is anticoagulated, has depressed consciousness, progressive or fluctuating symptoms, papilloedema, neck stiffness, fever, or severe headache at onset. These are features where missing hemorrhage, mass effect, infection, or subarachnoid hemorrhage could be dangerous. CT angiography is added when you suspect an underlying vascular cause. Think aneurysm, arteriovenous malformation, subarachnoid hemorrhage, lobar hemorrhage, young patient, or an atypical location. In simple terms, non-contrast CT tells you there is blood. CT angiography helps explain why the blood is there. Management begins with resuscitation and preventing secondary brain injury. Assess airway, breathing, and circulation. Check glucose because hypoglycemia can mimic neurological deficits. Treat fever, assess swallowing, and manage the patient in an acute stroke or neurocritical care setting. VTE prevention is important, but early mechanical prophylaxis is usually preferred until bleeding risk is clarified. Stop antithrombotic drugs immediately. If the patient has warfarin-associated intracerebral hemorrhage, give prothrombin complex concentrate and intravenous vitamin K. This is a major MRCP point. Do not just stop warfarin and wait. Reverse it urgently. Blood pressure management is also important. In acute intracerebral hemorrhage presenting within 6 hours with systolic blood pressure between 150 and 220 millimeters of mercury, rapid blood pressure reduction can be considered. A common target is systolic blood pressure of 140 millimeters of mercury or less, but avoid an excessive drop, especially a fall of more than 60 millimeters of mercury in the first hour. The balance is important. High pressure may worsen hematoma expansion, but too rapid a fall may reduce cerebral perfusion. Neurosurgical discussion is needed when there is cerebellar hemorrhage, hydrocephalus, mass effect, an accessible lobar clot, or aneurysmal subarachnoid hemorrhage. In aneurysmal subarachnoid hemorrhage, the aneurysm needs to be secured, either by coiling or clipping. Nimodipine is commonly used to reduce the risk of delayed cerebral ischemia from vasospasm. MRCP trap. Do not treat all sudden focal deficits as ischemic stroke. A patient with severe headache, vomiting, reduced consciousness, seizures, or anticoagulation needs urgent CT before antithrombotic or thrombolytic decisions. If you remember one thing, remember this. Hemorrhagic stroke causes damage by bleeding, pressure, reduced perfusion, and secondary inflammation. CT confirms the diagnosis. Anticoagulation reversal can be life-saving. Blood pressure needs careful control, and posterior fossa bleeds need urgent neurosurgical attention. Quick recall. A 72-year-old patient with long-standing hypertension suddenly develops left-sided weakness and drowsiness. CT shows a deep right basal ganglia hemorrhage. What is the underlying small vessel mechanism, and why does this location fit hypertension? The answer is lipohyalinosis with Charcot-Bouchard microaneurysm formation in small penetrating arteries, which classically causes deep bleeds in areas such as the basal ganglia, thalamus, pons, and cerebellum. A patient on warfarin presents with sudden headache, vomiting, reduced Glasgow Coma Scale, and CT-confirmed intracerebral hemorrhage. What treatment step must not be missed, and why is stopping warfarin alone not enough? The answer is urgent reversal with prothrombin complex concentrate and intravenous vitamin K, because active anticoagulation promotes ongoing bleeding and hematoma expansion, so simply withholding warfarin is too slow. Do subscribe to the channel for further videos.